All right, everyone. So week 7, where we are being introduced to MDMA-assisted psychotherapy. So the first chapter that we read was just simply titled MDMA, and I'm going to go over some highlights of this reading. So MDMA is also known by other names such as Adam, ecstasy, or Molly, and has been taken by millions of individuals over more than 40 years, the vast majority of those in non-clinical, quote unquote, recreational settings. MDMA has been around longer than psilocybin. It was first synthesized in 1912 by a German pharmaceutical company named Merck as a possible hemostatic drug. So this is an agent that checks bleeding. It's one that shortens the clotting time of blood. And then some animal testing was conducted in the 1970s, but there were no human studies conducted until later, namely in the 1990s. So the use of MDMA started spreading in the late 1970s with 2 different tracks: therapeutic use by psychotherapists and recreational use. So therapeutic use was done in therapeutic settings, not necessarily in research settings. And then Alex Shulgin and his wife, Anne, were key leaders in the MDMA movement in terms of moving this into a more structured therapeutic space. So several hundred therapists in the US used MDMA in their practices until it became illegal in 1985. During this time, there were published series and case reports by psychiatrists describing the therapeutic effects of MDMA. Therapists focused on the therapeutic potential of MDMA and explored safe and effective ways to use it. Again, this was still in a time where the research in this was a little bit methodologically shaky. Therapeutic work with MDMA was intentionally carried out with little publicity due to concerns about criminalization, which ended up happening anyway. Despite all of these precautions, recreational use increased. And in 1984, the DEA recommended placing MDMA on as a Schedule I substance in the Controlled Substances Act. And as we know, all of the psychedelics that are placed in a Schedule I classification are there without any support, without any true rationale, scientific rationale. So under the underground use and international exceptions. So the DEA in 1984 recommended it. In 1985, there was a decision to criminalize MDMA, and this took this movement, the therapeutic movement, underground, where there were still over 60,000 patients that were treated between 1985 and 2017. So over the course of 22 years, my math is right. Yeah, 22 years, 32 years. Anyway, 32 years. Yeah, it's 32 years. The decision also made clinical research more difficult due to added regulations and funding scarcity. As we know, MDMA research has really almost exclusively been funded through MAPS or through private funding. Internationally, Switzerland granted permission to a group of psychiatrists to use MDMA and LSD for therapy between 1988 and 1993. And the Swiss Medical Society for Psycholytic Therapy reported a good safety record and positive patient outcomes. And some of the SAPT members conducted phase 2 clinical trials with MDMA and LSD in Switzerland that were funded by MAPS, the Multi-Dimensional Association for Psychedelic Studies here in the United States. So subjective effects: MDMA is administered orally, typically on an empty stomach, for the same reasons that I talked about with psilocybin of the majority. So MDMA works on primarily on serotonin receptors, or serotonin system as well. And about the majority of serotonin is in our gut. So if you have food in your digestive system, particularly if it has a high fat content, that is going to attenuate the effects of MDMA, and it's also going to not prolong, but delay. It's going to delay the effects, ultimately kind of prolonging the entire, it's not prolonging the entire experience. Yeah, it would, because you're starting to feel the subjective effects within 30 to 60 minutes. You wouldn't really start to feel those subjective effects until like 120, 160 minutes, which just prolongs the entire thing and then kind of throws off the whole structure of the process. So onset of subjective effects is between 30 and 60 minutes, up to 90 minutes in treatment trials. Peak effects are from 90 to 120 minutes. So about an hour and a half to 2 hours into your experience, or when you're really starting to feel peak effects, and those last between 3 and 6 hours. Then remember elimination half-time, which means that half of the total effect of the substance is like when that half-time happens is between 8 and 9 hours. So that's after when half of the dose is essentially eliminated from the system. MDMA is different from classic psychedelics in terms of hallucinations and disorientation. So this is one of the characteristics of MDMA that makes this different from psilocybin, where with psilocybin, it is a very intensely internal experience with eye shades, headphones. MDMA, when used in not only clinical trials, but therapeutically in clinical trials, because otherwise what I would be saying is being done illegally, is you can do some traditional type talk therapy, not in the sense of you're like analyzing what's happening, but you can engage for prolonged periods of time with the participants, which hopefully you read the protocol or the manual this week for MDMA for PTSD, and you could read the transcript between the guide and the participant, where there is some extended periods of communication through while the participant is experiencing the effects of MDMA. Whereas in psilocybin, our job as guides, like for example, in the trial that I was a part of, our job as the guides was as soon as the participant started talking to us or started to mention something, we would invite them to dive back into the experience. With MDMA, you can engage with the participant differently, so you can have some conversation with them. But your positionality is super non-directive and very affirming, but I'll talk about that a little bit later. Okay, some alternative terms. As we know, MDMA is also referred to as a psychedelic or a hallucinogen. That's all of the substances that we'll be talking about this semester. So it also is called an empathogen, which refers to increased empathy for others and self, and an entactogen, which refers to increased self-awareness and ability to touch within. So that is both of these components, or both of these, like constructs, are also a part of the psilocybin experience. Different from psilocybin, MDMA does promote verbal interaction. So again, as you could see in the manual, the participant really wanted to talk about what was going on, and that is fundamentally different than the experience with psilocybin. There is less tendency to cause fear and anxiety compared to classic psychedelics, such as psilocybin. So some of the therapeutic effects: reduce defensiveness and fear of emotional injury. So this is why it is really preferable and really being looked into seriously for PTSD, because that's some of the reasons why people don't touch any of their trauma. There's a temporary anesthesia of the neurotic self. So just, the analytical self, the judgmental self, the, in some ways, like kind of idiosyncratic self, that part of you can kind of take a seat, and it opens up a more open, exploratory, kind of non-judgmental piece of your identity or part of you. There's feelings of well-being and fear and anxiety lift. Again, very good, a good complement or adjunct for trauma work. Shift in perspective and reframing of beliefs. The rationale behind this is such a a deeply sensory experience where it's not as though you're seeing images or you're hearing things, but it's this all-encompassing, similar to kind of the saying, like, I just felt it in my bones. Like when somebody just knows something to be true, it's like this deep intuitive experience. That's what traditional psychotherapy can't offer somebody. So it is it's just this holistic, more encompassing sensory experience. And it facilitates direct expression of feelings and opinions. So this is in many ways kind of goes against the grain, and I'll talk about this in later slides about like gender norms, for example, where, men are taught to suppress this part of them, their expression of emotions, of vulnerability, of insecurity. But really what MDMA can do is throw those, in many ways, arbitrary gender norm rules away, and really encourages the expression of feelings and opinions in a really, not necessarily euphoric, but in this like very non-judgmental space. So some challenges with MDMA assisted psychotherapy: there's anxiety and loss of control, which can occur during the initial effects. Really common, particularly with anybody who does have a little bit of trepidation going into the experience, or maybe this is, a truly novel experience for them of, these sensory experiences that are very new. That's generally anxiety inducing for any human. We don't really like novel and very unexpected effects. Processing traumatic memories can be challenging and painful. So in terms of so when the word processing, when we think about that traditionally with psychotherapy, just traditional psychotherapy, that's talking through it, right? But with psychedelic assisted therapy, it is a different type of processing, because in many ways you're experiencing it again in this like fully engrossed sensory experience of like every sense of the word of sensory, where you're processing it through some imagery, through just feelings that are coming up in your soul, that it's a different type of processing. So again, this can be this, very novel experience where the guide is so important and pivotal in terms of the grounding of this experience. Participants may still experience pain despite the helpful effects of MDMA, emotional pain primarily. Revisiting traumatic experiences without being overwhelmed is not necessarily a challenge of this, but it's a possibility. And quite frankly, one of the leading reasons why MDMA is being tested with an indication for PTSD. MDMA assisted therapy may be painful, but less anxiety inducing. So again, this is really in many ways no more painful than traditional mentally and emotionally painful than traditional psychotherapy when touching any sort of trauma. So neurophysiological effects. This MDMA stimulates the release and inhibits uptake of serotonin, dopamine, and norepinephrine. So it works on these three neurotransmitter systems. Most potent effects are on serotonin, having an affinity for 5-HT2A receptors, which should sound familiar. This is the same receptor that psilocybin has affinity for. Pre-treatment with serotonin reuptake inhibitor attenuates the effect. So that's another way. We talked about this either in week 1 or 2, where when you are testing what neurotransmitter systems might be affected by this, you also want to understand what can stop the effects of something like MDMA or psilocybin. So serotonin reuptake inhibitors, or SSRIs, attenuate the effects, which indicates to us that it works on serotonin receptors primarily. And then it is contraindicated with monoamine oxidase inhibitors, so don't use those together. and self-limiting effects with repeated administration due to serotonin production and inhibition, which basically means that you build a tolerance. So when you repeatedly administer MDMA, the effects just aren't as powerful because you are kind of, in some ways, kind of overloading the serotonin system. So neurobiological effects and imaging: increased serum levels of oxytocin and arginine vasopressin. MDMA increases interpersonal trust and decreases reactivity to threats. So you can see later there's decreased activity in the amygdala, which is kind of our threat center, our fear center. There are changes in cerebral blood flow and functional connectivity. There also is decreased activity or blood flow to the hippocampus and increased blood flow to the prefrontal cortex, and decreased resting state functional connectivity in certain brain regions. This is another way of saying there's decrease in the default mode network. So again, same as psilocybin. So possible chronic toxicity. This has been a part of the narrative for a long time with psychedelics. And there was some extremely high doses being given to animals that in no way parallel what's being given to humans or what humans even take recreationally. So there is some, in some ways, these like false equivalencies with animal studies. There's a reduction in brain serotonin production with repeated use or high doses of MDMA, which doesn't persist. So in long-term follow-ups, these reduction in serotonin, which is our happy neurotransmitter, that can be depleted or decreased like several days after administration, but generally doesn't persist beyond that. So there's no increase in neurotoxicity markers associated with neurodegeneration. In fact, we know that psychedelics increase neuroplasticity. Slight reductions in brain serotonin in monkeys who self-administer MDMA. Again, I don't know how often they are self-administering. I don't know the amounts that they have access to, but just trying to understand. In many ways, these are what are considered like preclinical trials. Preclinical really means like before using it with human beings. So that's generally on animals. And then damage to serotonin axons observed in rodents and primates with high doses. Again, not equivalent doses to what is given to humans. Like these are very high doses. And then there have been some, in some ways, like naturalistic studies with neuropsychological naturalistic studies of ecstasy users. So there's conflicting and retrospective studies on ecstasy users so there's conflicting results from ecstasy users' cognitive functioning, and these are all retrospective studies. So there's not really, an understanding of how somebody was like pre and post in terms of like fMRIs or like actual brain activity. So these are mostly just people who have used ecstasy in the past, and in some ways are self-reporting some of their cognitive function. So some of the confounding factors in these studies, which create some conflict, is premorbid functioning. So, how were they functioning cognitively before? Drug purity, were they just taking ecstasy? Unlikely, or was it altered in some way? And then polydrug use, are they using other things? So it's not really this like the methodology isn't very clean. So there was a study with a relatively pure sample that failed to demonstrate marked cognitive effects in ecstasy users, which makes sense. Then a prospective study found an association between ecstasy use and verbal memory, with some decreases in verbal memory. And then there were baseline differences in cannabis use and attention-seeking behavior that may have influenced the results. So, again, this is with some polydrug use where individuals who used ecstasy were also using cannabis, and some potential, conflated results were reported. So acute self-limited side effects in clinical trials. There are common but self-limited side effects in phase 2 clinical trials of MDMA-assisted psychotherapy. So self-limited just basically means time limited. that there are effects of MDMA, but they are acute and not persisting. So when somebody is under the effects of MDMA, anxiety is the most common side effect, like unpleasant side effect. Early anxiety responds to reassurance and relaxation techniques. So when somebody has just ingested MDMA and within that first 30 to 60 minutes, when anxiety can kind of peak, that's when us as guides stepping in and grounding and reassuring, this is where preparation is so important, and building that therapeutic alliance is so important, and then having that trust in the room. And then anxiety later in the experience may be related to specific content, and it's encouraged that there is further exploration. So again, reassurance, you are safe, I am right here. What are you seeing? What's going on? And then an invitation to dive back in, because that's the best way to process in when somebody is under the effects of psychedelics, is not to run away from it, not to try to escape from it, but to move toward it. And then anxiety, in the over 300 sessions that up until this book's publication that had been done, there was only one time that anxiety medication needed to be used. So super low, very rare incidence of that. So some regulatory challenges within MDMA clinical research. It continues to be widely ingested despite FDA regulation process. Again, this is in recreational, non-clinical use. Regulatory challenges have really delayed MDMA research. Rick Doblin kind of spearheaded a lot of this in the 1980s, and we're over 40 years after that, still trying to get any sort of FDA or DEA approval. MDMA clinical research is sponsored by a small not-for-profit organization that's MAPS. And phase 3 trials will determine FDA indication for legal treatment. Initially, and it says it in a later slide, that this is like anticipated to be in 2022. Obviously, we have passed that. Current estimations for this is mid 2024 that MDMA will get an FDA indication. And then, like I said before, non-scientific factors, very politically motivated factors, caused a 40-year delay in investigating MDMA as a treatment, even though there were really only promising results from it. So some history and progress of MDMA research. MAPS contracted with a chemist, Dr. Nichols at Johns Hopkins, to produce legal MDMA for research purposes. And then governments actually funded the majority of, or actually all, I think, of the preclinical MDMA studies. So MAPS didn't have to fund that, so they could fund the clinical trials. And the first FDA approved human administration of MDMA was a phase 1 trial. And we talked about all the different phases either last week or 2 weeks ago with healthy volunteers. So no indications for that. Again, with phase 1, quite strict inclusion criteria for that. And after phase 1, there were phase 2 trials that were for specific indications like PTSD. And then currently what is happening right now are phase 3 trials. So looking for FDA approval, and then phase 4 trials will occur before there is essentially like market access to MDMA. And then, as I've said before, obstacles and political pressures had influenced the course of MDMA research, again, delaying it decades. So some future prospects for MDMA, there's possible chronic toxicity concern based on animal studies, but we know that those are potentially conflated results. There's inconclusive findings from neuropsychological studies of ecstasy users, which in some ways, I'm just kind of overviewing what I've covered so far. There's self-limited side effects observed in clinical trials, again, which meaning that these side effects of things like anxiety, they don't last long. And then regulatory challenges and delays in MDMA research, I just talked about that. And we are currently in phase 3 trials, and we're still trying to figure out the best safety and efficacy protocols, procedures, policies for the use of psychedelics, specifically MDMA. So MAPS sponsored, so again, the Multidimensional Association for Psychedelic Studies right here in California. So between 1994 and 2018, there were 9 phase 2 clinical trials of MDMA-assisted psychotherapy completed. Trials were conducted at 7 different sites in 4 different countries. 6 of these studies focused on treating individuals with PTSD. The FDA has granted permission for phase 3 trials. Again, these are currently ongoing. And then I believe in 2018, MDMA was granted breakthrough therapy designation by the FDA. So this is what was the catalyst for phase 3 trials. So phase 2 clinical trials, participants underwent careful screening and baseline measures by an independent rater. All of the things that I talked about in last week's, I don't know if it was week 5 or 6, presentation about all of the specifics in the screening process apply to MDMA as well. So one of the main differences between psilocybin administration or psilocybin trials and MDMA trials is MDMA tends to be administered more often. So these phase 2 clinical trials enrolled participants that had 3 preparation sessions with a male-female therapy team. So yes, we're like hanging out in the binary here. They want, the thought behind this was some of safety, and then with having co-therapists of different genders, of providing different perspectives as well. And I think in many ways too, I think it was strategic for any sort of transference and countertransference of being able to leverage some of that, maybe mitigate or manage some of that. So these 3 preparation sessions, they generally last 2 hours, so about 6 hours of preparation. Then individuals are randomized to either receive MDMA, an inactive placebo, or a low dose of MDMA as a comparator. MDMA or comparator administered in 2 8-hour therapy sessions 1 month apart. So they had an initial MDMA session, had 4 weeks of essentially kind of like an integration / preparation, and then a second administration. So that second administration is fundamentally different than the first because you already have kind of an idea of what you want to explore in more depth. You understand the process a little bit more. There's the anxiety is lowered because it's no longer like this very novel experience. And then follow-up integration sessions, the participants stayed overnight. The guides don't leave until the effects of the medication have completely worn off, and then there is an aide that stays overnight with the participant, and then the participants are called every single day for a week after the sessions just to check in with them to make sure that they're not having negative side effects. So some results of these trials: pooled data and analysis showed a large between group effect size of 0.8, and y'all, for those of you who are not familiar with effect sizes, 0.8 is a large effect. It goes from a perfect negative association of -1 to a perfect positive association of +1. So 0.8 is very large and very significant. So a response to psychotherapy with MDMA was comparable when participants received the active dose after receiving the placebo or low dose comparator. So this is what we've learned is a crossover format of a study. So when compared to the individuals who received the psilocybin or the MDMA first, and then once the placebo group crossed over into the experimental group, those effects were comparable. Then the gains, whatever those were, insight, less anxiety, less trauma responses, they were maintained by most participants with significant improvements in CAPS scores. So this is a PTSD scale. And secondary measures showed improvements in depression symptoms and sleep quality, which we also know is really huge in, sleep hygiene is very important for our mental health. Personality factors such as openness and neuroticism also showed positive changes. So higher openness, lower neuroticism. So phase 3 study design and blinding challenges. So as you may imagine, taking a high dose of something that is going to put you to sleep and taking a macro dose of something that is going to potentially be one of the most meaningful experiences of your life can be kind of obvious who gets what. So maintaining a double blind, again, this means that the researchers and the participants don't know if they're in the control or experimental group. It's just challenging. So for the study that I was a part of, we had to take my co-therapist, my postdoc mentor, and I had to take we did on like a Likert scale. First we said if we thought that they were in the control or experimental group, and then we would rate our confidence in that. And I think there was only like 1 or 2 times of the like nearly 30 participants that I worked with that I wasn't very sure that they were either in the control group or experimental group. So in phase 2 trials, various low doses of MDMA were used as active comparators to improve the blinding, though it didn't really help. And then they were playing around with doses of 75 milligrams, 50 milligrams. Doses of 50 milligrams and below actually increased anxiety without being helpful, interfering with psychotherapy. So they actually learned that some of the low dose comparators actually had worse outcomes. So in order to improve the outcomes, they had to increase the dose. And then like recent and current phase 3 trials, MAPS has sponsored phase 3 trial that is has been completed at many sites in the US, Canada, and Israel. There's an inactive placebo that's compared with active doses of MDMA in 3 8-hour psychotherapy sessions. So they are giving them 3 doses as opposed to like with psilocybin, for example, that's generally 1 dose. Then the results of this are pending, and there's promising future prospects for MDMA-assisted psychotherapy as a potential treatment for PTSD, which I find extremely exciting. This is actually the place where I want to make my mark in this field for anybody who cares, is working with trauma and seeing how psychedelics can help with that. So just some ways that MDMA has been used, as you read about MDMA for anxiety and autism. So there was a study done here in Los Angeles, that's where I am located. There were 12 adults with autism that were randomized to either receive MDMA or an active placebo. They found significant improvements with anxiety. There was a large effect size at primary endpoint, which just means at the end of the trial. So after like the last session of integration, and then a 6-month follow-up, which generally that's the longest follow-up that our studies have. And then, so there's a potential for MDMA to be helpful with autism and anxiety that is associated with autism. Then MDMA for anxiety in life-threatening illness or a terminal diagnosis. So there was a study that was published in 2020 with 18 participants that had randomized participants to either experimental or control. It was a double blind. And they found a significant drop in state trait anxiety inventory. So an inventory for anxiety. There was trending significance, large effect size, and a good safety record. So good. There were so here is also indicating that MDMA might be helpful in anxiety for life-threatening illnesses or terminal diagnoses. And this is where, so as a couple and family therapist, where I would love to see this field move, because MDMA is unique in terms of its ability to have an effect on individuals that allows them to communicate while under the influence in a different way than psilocybin and ketamine. So MDMA has been used in cognitive behavioral conjoint therapy, or CBCT, for use for PTSD. There's a study that was done either in New York or Canada, I'm not sure. The researcher's name is Candace Monson. I think she might be in New York, I'm not sure. But MDMA has been used with couple therapy for enhanced communication. And this was there's a manual that's actually created for CBCT for PTSD. So, I mean, that is available. Like if you just Google it, it will come up for you. And so MAPS funded this study for CBCT with MDMA for PTSD. And there were promising results of this. It was open label, meaning that everybody knew what everybody was getting. And that this wasn't a RCT, this was in many ways like a proof of concept. So all of the couples that were part of this trial received MDMA, and this was the basis for expanding this study. So MDMA was actually used in couples therapy prior to the 1985 scheduling of MDMA as Schedule 1. But there's not really a clear path of how to use it, because if you think about with psychedelics, they're moving toward being indications for certain diagnoses. And many times, as we know, with relational therapy, we hang out in the Z codes and the V codes. So unless we have a patient or a participant or client who has an individual diagnosis, we don't really have relational diagnoses. So even if MDMA, psilocybin, ketamine, well, not ketamine, because this already has FDA approval, but psilocybin and MDMA, even if they become even if they are granted FDA approval, the use of this in a relational setting is still kind of up in the air and not really clear how that's going to happen. So representatives from MAPS representatives of MAPS and had meetings with the National PTSD Center just to see, what can we do here? How can we move this forward? And then, so this was Candace Monson and Michael Mithofer for cognitive behavioral conjoint therapy with MDMA. So they're collaborating on that. They have collaborated on that. They've done a proof of concept study that has been published that we will be actually reading next week. And through this trial, it was learned that MDMA has helped couples overcome obstacles and that CBCT provided valuable skills. So if you think about MDMA and as an empathogen or even an entactogen of being more attuned with your own stuff and increasing empathy, like that would inevitably improve a relationship. So for this trial, what they did was one of the participants had a diagnosis of PTSD. So that's how this was able to happen. So again, if we have couples where one partner has been diagnosed with PTSD, that could be a path. But just in terms of couples who are like struggling to connect with one another, like kind of running the common gamut of what we see in couples work, many of those couples don't actually meet a diagnosis for anything. So again, just kind of muddy waters there. So therapeutic methods for MAPS-sponsored MDMA clinical trials is that the therapy is delivered by 2 co-therapists in an aesthetically pleasing room. Y'all saw a picture in the text of what that looks like, where there is the use of a futon or a sofa for participant comfort. They should be able to lie down. They shouldn't be having to sit in a chair for 8 hours. MDMA sessions last 8 hours. There's an overnight stay with a night attendant on site. So they, because again, like driving is contraindicated after a psychedelic session, and they have a loved one, a trusted other who has committed to picking them up the next day again. So some influences on the therapeutic method. So, Stanislav Grof and the Grof Transpersonal Training Program is really what informs MAPS, because MAPS has their own MDMA guide training, and it's influenced by Grof. There's contributions from therapists experienced in MDMA and psychedelics. So I guess one of the, I think it would be just not necessarily a drawback, but just one of the I think thematic kind of struggles in this line of work is this training through MAPS costs nearly $9,000 and it takes 8 months, but I'll talk a little bit more specifically about this training. So it is influenced by indigenous cultural practices with psychedelic plants, so this training, and then there's an incorporation of learning from diverse sources, from researchers, from clinicians, from people of various professional backgrounds. So I'm just going to kind of highlight again some of the effects of MDMA. It temporarily reduces fear and increases positive emotions, allowing for some exploration of traumatic experiences. It enhances interpersonal trust without clouding the mind and like giving your intellect kind of a day off. It allows emotional engagement during trauma revisitation. So as we know, dissociation is extremely common as a way of coping with any sort of trauma and re-experiencing of trauma. So this allows for emotions to still be present in that experience, but not like the overwhelming fear, terror, that they are more like calming, not necessarily positive, but at the least they're more neutral. So it facilitates the expression of fear, anger, and grief, allows for the expression of that, hopefully in this like very non-judgmental, just open way. And it enables empathic rapport and secure attachment. So as we read in the chapter about some potential indications of using this with children, I think that's extremely interesting, of children who have experienced some ACEs and seeing if that could potentially benefit the trajectory of their life in terms of, an intervention for some of the negative effects of ACEs. So I'm summarizing some of the quotes that we read about in the chapter of the drug lets your mind relax and get out of the way. So we're not analyzing, we're not intellectualizing, giving our mind kind of the day off and just to feel. So the real hope with MDMA is that you're just really present in your feelings. I felt deeply connected to painful feelings without anxiety. Each time I move through difficult emotions, it feels better. The experience provided a clear perspective and a sense of support. I have respect for my emotions now and can handle them. Some holistic aspects of MDMA-assisted psychotherapy. So there's the inclusion. It's an inclusive exploration of life experiences and relationships. Again, it's engrossing. It's an embodied experience in a way that talk therapy is not. There's a potential for accessing spiritual and transpersonal experiences, again, in a way that maybe like deep meditation can do that, but not necessarily in traditional psychotherapy. There can be a release of body tensions and nonverbal healing. There's individual variation in the therapeutic process, of course. I mean, I would say just like traditional psychotherapy, this is, personalized on a higher level. So the personalization, the catering of this is very, very individualized. Like no two people taking MDMA are going to have the same exact experience. And quite frankly, no one person taking MDMA multiple times is going to have the same experience either. So therapists supporting each individual's innate healing capacity. So I'll talk a little bit more about that in terms of like the role of the guide, and that non-directive positionality you're going to take. So how is MDMA assisted psychotherapy different from other methods? So it's 8 hours, very different than traditional like 45 to 60 minutes. There are 2 co-therapists, which is much more uncommon in traditional psychotherapy. You also can listen to music with eye shades and have headphones on. Again, with MDMA, you are invited a little bit more often to take those off and engage in a conversation, but you are very much invited to have an internal experience. Then naturally, there's a use of a drug to shift consciousness that is not there in traditional psychotherapy. And there is an inner directed approach where, you are invited to dive in and lean into your inner wisdom, lean into your inner expertise in a way that's just different than traditional psychotherapy. So some features here: imaginal exposure, a little bit different than like prolonged exposure, but this very much like kind of spontaneously occurs within an MDMA session, where you have this vivid imaginal exposure. You are seeing things, you are feeling things in a way that is like deeper than just a visualization, like you would do with some prolonged exposure. So we were given two examples here with a middle-aged woman with severe PTSD, revisiting her trauma and how that was transformative for her. The military veteran who was embracing his rage as opposed to trying to like lock it in this box and throw it away. And he did this through revisiting some of his traumatic experiences in combat. There are advantages of a relatively non-directive approach. And so I think the worst thing that psychedelic guides can do is just get in the way of their participants, of their clients or patients, whatever setting that you will be in. That when we bring in our stuff or our intellect, I think it really takes away from the experience. And then MDMA also has the potential to enhance a fear extinction. So where there may have been a traumatic experience, that the fear of that experience decreases or potentially even goes away. So cognitive restructuring is used in psychedelic treatment as well. As we know, cognitive restructuring comes from cognitive behavioral therapy. This can happen with, like it says at the bottom, there's spontaneous cognitive restructuring during sessions without therapist direction. So this is something that just spontaneously happens. We don't need to do, Socratic questioning or any sort of, drilling down to the core beliefs or schemas for this. It just kind of happens. And participants are expressing thoughts in the cognitive restructuring. What has been observed to happen is participants expressing expressing thoughts that they had never thought before. So they're just, again, spontaneously kind of reframing, thinking of things in a different way. And then a big thing for us to keep in mind as clinicians, guides, professionals, is paying attention to our own countertransference and any of the clients, participants, patients' transference toward us. So this is a really normal part of the process. So we read about that in the chapter this week, where the participant turned to the female guide and said a few things to her, and then turned to the male guide and then said, hey, I needed to do that first before I could turn to you, where they were seeing very much like mom and dad images in terms of projections. So that's a normal phenomenon. It should be something that is leveraged, that is used, that is open and explicit within the process. Also, one of the things that we have to really keep in mind as guides with psychedelics is that participants are attuned to our verbal and nonverbal expressions in a much deeper way than our clients who are not under the influence of any sort of psychedelic. So we have to be really aware of our body language and be really thoughtful about how we speak to our participants. And there's an increased capacity to acknowledge and discuss transference issues. You need to have an increased capacity for this as a guide, and you need to be able to facilitate conversation about that as well. So our own awareness of our own reactions and honest engagement in the process is cornerstone to this type of therapy. So then we talked a little bit, or read a little bit about like parts concepts, or the multiplicity of the psyche. So MDMA raises awareness of different parts of the psyche, again, referred to Gestalt and IFS, internal family systems work. There's a simultaneous emergence of self energy for exploration with compassion. So think about like self in terms of internal family systems, that capital S self of in many ways kind of the governor of the other parts. So that part is the most pure, it is unbreakable, it is the most honest form of yourself. That's what this means by self energy. You're exploring the psyche's multiplicity with greater clarity. Again, because in some ways it manifests itself in visual, auditory, like just these deep feelings, that's different than if you're just trying to articulate it through words. And then integration of MDMA assisted psychotherapy with existing therapeutic models. We can kind of play around with it. Right now, it is really heavily either psychodynamic or CBT. But I think it has application with other approaches as well. So with MDMA moving toward an FDA approval, I talked about this last presentation with psilocybin, but it has to go through the REMS process, the risk evaluation and management strategy. So here are like the proposed what's the word I'm looking for? Not credentials, but what we need to aspire to and what we need to abide by as a field when doing this as it moves toward FDA approval. So MDMA should be prescribed by certified therapists with specialized training. This empowers proper knowledge and expertise in administering MDMA therapy, and it increases the safety and effectiveness of the treatment. It should be administered only in certified clinics. This provides a control and monitored environment for therapy sessions, and it ensures adherence to safety protocols and guidelines. There should be safety screenings for specified patient populations. So we should engage in a comprehensive evaluation of the patient's medical history and mental health condition, and be able to identify potential risk and contraindications for MDMA therapy. People should be prohibited from driving for 5 half-lives of MDMA. So if a half-life is 8 to 9 hours, multiply that by 5, and that's when somebody can get behind the wheel again. So this recognizes the impairing effects of MDMA on cognitive and motor functions, and it ensures patient and public safety during and after treatment sessions. And then there should be direct shipment of MDMA from the manufacturer to the prescriber for clinic dispensing. So this maintains strict control over the distribution and handling of MDMA and prevents unauthorized access and misuse of the drug. So these are the proposed guidelines. I think that's what I was looking for, guidelines for the use of MDMA in therapeutic settings. So the therapist training program, these are the components of the $9,000 training that I was referring to earlier, that there is provided by MAPS. It's an online training module that provides foundational knowledge on MDMA assisted psychotherapy. It covers theoretical aspects, safety protocols, and ethical considerations. There are also there's a 6-day in-person training that's either offered in like San Francisco, or I believe in somewhere in New York. And this includes video sessions from research sessions for discussion and analysis. It allows therapists to learn from experienced practitioners and enhance their skills. It includes individual activities to expand skills. There are workshops and holotropic breath work for somatic therapy trainings. It enables therapists to integrate complementary techniques into their practice. You also will engage in role play with co-therapists. This simulates therapy sessions to practice collaboration and coordination. And it enhances therapists' ability to work effectively in a team setting. Finally, you would receive supervision and feedback where you are taping your own sessions, and the supervisors will review these videotapes and provide you feedback in video conferencing meetings. And then this component offers guidance to support therapists during their training journey. So that's all of the things that you would get in this training program. And so some promise in terms of MDMA assisted psychotherapy. Again, in 2018, it was given a breakthrough therapy designation by the FDA. There are international phase 3 trials that are happening. It says a crucial step toward clinical approval expected by 2022. Again, it's now expected in 2024. One of the cool things about MDMA assisted psychotherapy is bridging. I'm going to talk about this more in depth in the next chapter. Bridging psychopharmacology and psychotherapy, where MDMA and psychedelics offer a new direction in psychiatry and psychology. I'll talk a little bit more about what that shift might look like. This also, MDMA has historical significance starting with LSD in the 1930s. And then there's the potential for psychological healing and growth that I think in many ways we're only kind of touching the potential of what MDMA and psychedelics in general can help people with. So now let's talk about the next chapter we read, therapeutic and social uses of MDMA. So when I was talking about psychopharmacology and psychotherapy kind of coming together, this is what I meant here in terms of the paradigm shift in mental health, which I think is really powerful how this was talked about in the chapter of we really do work from a suppressive model. We are trying to suppress symptoms. The medical model that we currently have in terms of, antidepressants that in many ways kind of just dull emotions, anti-anxiety medications that just kind of dull emotions, that MDMA is a categorically different experience where you feel in ways that you've potentially never felt before. So this is a potential transition as a field from a suppressive model, like again, suppressing symptomology, to an evocative model of just like, what is your mind like? What are the possibilities of it? And so this focuses on honoring the psyche and its innate healing power, which again, if we think about kind of the mindset of the field now, it's a kind of what's wrong with you. Let's fix what's not working right in your body. Let's block the serotonin. Let's work on norepinephrine or dopamine. Let's, work on MAOIs. So this is a fundamentally different, where this is saying you have all the resources you need. Now let's just unlock them. And that's what MDMA does. So there is right now, as I said, a dominance of a suppressive psychopharmacology, medications for symptomatic suppression without any curing, kind of band-aids, not really looking at what the crux of any of the suffering is. There's a clouding of consciousness and hindering deeper psychological processing, again, through some of the dulling effects of the medications, the psychotropics that we do prescribe as a field. So there's an emergence of new paradigms. There's a recognition of the intrinsic wholeness of the body, mind, and spirit, and a respect for the inner world and its healing potential. MDMA can be a catalyst for healing, where it enables deeper exploration of the psyche and potentially goes beyond treating PTSD, offering broader applications in mental health. Same as we talked about with psilocybin with addiction, that in many ways, human suffering across diagnoses can be very similar. So why would this not work on potentially other applications? And then broader implications of MDMA use is the consideration of social and recreational contexts of MDMA. How do we educate people? How do we help that be more safe? How do we limit adulterating substances? And then questioning whether its value is limited to clinical applications. So are psychedelics only beneficial in very controlled environments? At this point, I would argue yes, but there's a lot to be learned. So psychedelic pioneers and therapeutic exploration. So here are some of the big hitter names in this of Adamson, Metzner, Downing, Grob, Ingrassi, Nichols, Shulgin, and Doblin. So these are just some of the names that you will probably hear throughout the field, and probably faces that you've seen in some of the publicity around this. So Anne Shulgin, like I said, her husband was helpful in creating some of the excitement around this, and she helped create some of the guidelines. We read about Leo Zeff and group tripping. These were organized weekend retreat type settings for psychedelic substances, and there were guidelines for safety and transformative experiences within ongoing relationships. So when they left the retreat, how do you engage with one another? There was an underground use and rise of the rave scene. So makes sense that this was influence on the development of rage culture and the plural movement of peace, love, unity, and respect, given what we know about MDMA and its effects on human beings, that peace, love, unity, and respect movement makes a lot of sense. And then there were grassroots harm reduction initiatives to support organizations for safer recreational use. Like these are like testing strips at, because the majority of use of psychedelics is at like festivals. And so there are organizations that set up tents where you can bring in the substances that you plan to use over the weekend. They can test them for if they are adulterated with anything, if they're pure, what is in them. And that's been a really great harm reduction initiative in terms of reducing overdose deaths and just reducing toxicity. So prohibition and the underground network, there was prohibition really created some negative public narratives around MDMA. The media focused on the dangers and risks of recreational use. There was a negative portrayal of hedonistic party culture without considering the value or benefits. Like MDMA was just categorically bad. Like if you take it, I think it's like kind of like the narrative with like bath salts. Like every time I hear about bath salts, I just think about the person in Florida that like bit somebody's face. So I just think about how I've been so conditioned to associate those two things, about like how powerful the media is in associating. So I like the narratives around MDMA. It's not the same as bath salts, but I'm just giving you an example. So there was underground networks and illicit therapeutic use. So there was a resurgence of underground practitioners exploring MDMA's transformational qualities. So it works, but it's illegal. So let's take it underground. There's the use of psychedelics and MDMA for treating various clinical problems, like we talked about in terms of PTSD, anxiety, depression, and other indications. The challenges and exposure of underground networks. So basically what would happen is like people were generally happy with, not necessarily happy, but like consumers of the therapeutic services underground generally were satisfied with the services, but they were only exposed when somebody had a grievance. So then, law enforcement would come in, shut it down. And then there was more of a balanced narrative and therapeutic advancement. So there's shifting perspectives on MDMA's potential beyond therapeutic contexts. And there's positive outcomes in treating severe PTSD and facilitating positive change in human relationships, as shown by some of the studies that I mentioned in the last section of the last chapter. So right now, what we're really doing as, I think, a society is reevaluating MDMA's value in the range of use. So we're seeing where it's applicable in in mental health, and I would argue all over the place. We are broadening the applications beyond specific diagnoses. One of the things that I would like to do in my own research is in some ways kind of lower the threshold for inclusion in studies, to where somebody maybe hasn't reached the criteria for PTSD, but they've undoubtedly experienced trauma. Like I'm just thinking about things like chronic trauma, like racism, homophobia, transphobia. Those are traumatic experiences, but not necessarily acute in terms of meeting criteria for PTSD. So that's my hope, is that we're in some ways expanding the inclusion criteria for who can benefit from MDMA. So yeah, I've covered all the rest of this. So biochemical activity and neurotransmitter release, I won't cover this too closely, but really one of the things that I want to highlight is like the lightest blue box in the top right of the release of neuroendocrine molecules. So MDMA leads to the release of vasopressin, prolactin, and oxytocin. And vasopressin and oxytocin are linked to love, bonding, trust, and social memory. So these are just positive effects. And this is another reason why this can be used relationally. So psychological relevance and effects, like I said before, there's a profound state of calm, clarity, and safety that is facilitated under the effects of MDMA. It produces or promotes introspection and self-examination, very similar to psilocybin. There's prospective pro-social and empathic responses, which would make sense in terms of being beneficial for couples work or relational work. There are common effects that are reported by psychiatrists, such as the enhanced ability to be open and be aware of emotions, decreased defensiveness, fear, and aggression, which again, just think about why people come to therapy. These are big reasons why. So this is a good adjunct, a good complement to what we're already doing. And then there's a construction of a speculative psychological profile. So this enhances connection between individuals, facilitates self-reflection and reduced fear related to past trauma, enhances interpersonal bonding and expression of deeper feelings, decreases aggression in communication, and improves forgiveness and acceptance of imperfections. So again, lots of the presenting issues that we see in therapy. So thinking about us and our role in this process, we want to be able to facilitate a deep bond, deep bonding and trust. So MDMA can enhance, like, so this is if when a facilitator has personal experience with MDMA. So this enhances our ability to connect with clients. It creates a sense of safety, alignment, and trust in the therapeutic relationship. So just so y'all know, if you were to go through the training process with MAPS, you would be administered MDMA. So you would have a personal experience with MDMA. And this reflects the foundation of psychotherapy based on unconditional positive regard. It increases your self-awareness and responsiveness. It promotes personal growth and recognition of any sort of blind spots in the process. Integration of personal psychotherapy and training. Again, I think this is just about like congruence in the process. And then the exploration of shadow elements. So inner work with MDMA facilitates therapists in recognizing and processing their own shadow elements. So just like, if you think about this again in IFS terms, your exiles, your maybe some inner child work where there's wounds, just parts of you that maybe elicit some feelings of shame. And then it supports personal growth and development of practitioners. So in terms of taking MDMA in a controlled setting. So MDMA cultivates intimacy and open communication. It opens the heart and creates a calm, confident, and sensitive clarity. It removes attachment concerns, trauma history, and critical inner narrative distortions. It allows for honest and direct communication of love and affection. Again, makes sense in the use with partners, but also if you think about the first relationship that we have, not necessarily maybe the first, I don't know, but one of the most important relationships that we have as human beings is the one that we have with ourselves. So it can deepen interpersonal connections. It facilitates deeper emotional connections and communication. It expedites and deepens interpersonal conflict resolution and relationship work. It enhances marital therapy and relationship growth. Again, this is an emerging, I hope, part of the field in terms of doing relational work. Only one like kind of contemporary study has been done with this, and that was with Monson's lab in either Canada or New York, I'm not sure. It enhances affective equality in relationships. It rebalances affective inequality and provides a space for open sharing, empathic connection, and reconfiguration of gender-based norms. So like I was talking about before, how we are socialized in terms of gender, where, men are taught to repress, to stuff, and women are socialized in some ways to express, but also then to kind of be shamed for expressing. Men are also shamed for expressing. So it, in many ways, kind of throws those out the window and just kind of lets you be a human being. Imagine that. There's an integration of insights into everyday relationship patterns. So recreational MDMA use can result in durable changes in intimate relationships. Couples gain insight and lessons that they then can integrate into their daily relationship dynamics. That's the purpose of integration. And then the aspect of challenging prohibitive narratives. Recreational MDMA use in committed relationships contradicts the perception of reckless or risky use, and it demonstrates real-world context where MDMA enhances relationship and communication. So addressing some psychiatric disorders and inner healing, there are many conditions that are related to shame and control that can be addressed using MDMA. Also, it addresses anxiety disorders by enhanced insight and reduced fear that can benefit panic, agoraphobia, and chronic anxiety. And it supports increased self-acceptance and reduced self-loathing. So again, a lot of really positive things coming out. We are exploring applications for severe depression. That's primarily been being studied with ketamine, a little bit with psilocybin, less so with MDMA. So again, just looking at these different applications. Like I talked about before, the potential for child and adolescent mental health. MDMA-assisted sessions with parents could facilitate a shift in parental awareness and improve family dynamics. It offers an opportunity for addressing issues of fit between child and parent in a single session. And then also potentially changing the trajectory or improving the trajectory of one's life, a young person's life who has experienced ACEs or adverse childhood experiences, or potentially adverse community environments. And then unlocking some new possibilities. It holds promise for addressing various psychiatric conditions and facilitating personal healing. And as we know, we need more research because it's been around for a long time, but it's only been being researched for about 30 years. So understanding the safety landscape, as we know, very safe from the nut study that I showed y'all in the graph of the harms of different substances. There's a long track record of use of over 30 plus years with nearly no adverse effects. The majority of use is recreational or underground. And there are some statistics with that, but like it says here, morbidity and mortality statistics should be placed in perspective. So any of the, like the statistic that they gave around emergency room admissions with psychedelics, there's like 9 times more emergency room admissions with aspirin. So, you know, we generally think of aspirin as really safe. So just kind of putting that into context. Then addressing any potential concerns, not the non-selective nature of thoughts and emotions solicited by MDMA. What this means is that you can't predict what you're going to get in an MDMA experience. So you can expect that there's going to be some like effects on the body, but in terms of what you experience, you have no idea. So that's what it means. It can be very, not necessarily random, but it is unique every single time. So that's a concern in terms of like recreational use of you're not quite sure what you're going to get. And we also know that set and setting is so important. And when those aren't controlled, you're really asking for a difficult experience. And then as I talked about before, the recovery period and concerns on days 2, 3, and 4, there is a little bit of dip in terms of mood, some depression that can be experienced, not by everybody, but it's just something to consider. And then, as I said before, there were critiques in terms of, or, you know, concerns in terms of neurotoxicity, but there are critiques in terms of the methodological shortcomings of those studies. And what largely happens when there is, you know, a dip in the serotonin receptor system or a deficiency with cognition, that those are temporary, that those you can recover from those. Yeah, so I mean, I'm going to kind of repeat a couple of things in terms of there's no serious adverse effects in hundreds of administrations. Again, one person needed anxiety medication to be administered. And then when there are any sort of risks that have occurred or like adverse effects, those are added into the informed consent. And so people who are participating in this are aware of any of the risks. And then just really understanding, you know, what are the implications of this being used in a medicalized setting versus an unsupervised non-medical setting? You know, do different standards need to be set? Do we need to have different conversations around those? I would argue yes. And then, there was this debunking of the prohibition narratives. They're, very biased, lacking any evidence, like what the narratives around MDMA being extremely risky. There was no evidence to support this. And then regardless of these narratives, the use isn't going to stop. So again, how do we make it as safe and beneficial as possible? And then this is where harm reduction strategies and good information come in. How do we inform the public, and how do we allocate funds and resources to education to make this as safe as possible? And yeah, there needs to be appropriate policies such as scheduling of this substance based on the actual degree of risk that's involved. So moving forward with safety, we one of the things that MDMA can do is bridge this gap between psychotherapy and psychopharmacology, this suppressive approach and an evocative approach. As in sum, there's an importance of harm reduction, information dissemination, and appropriate policies. And we really need to focus on understanding MDMA's safety profile and how we can enhance that. All right, so then moving on finally to the manual that I showed you. And I hope that this was helpful for you to actually see like what is done in therapy. So this would be a manual that is given to guides in MDMA assisted psychotherapy trials, specifically for PTSD, and how they navigate different situations. So just going through all of these really quickly. So this protocol was created by, this manual and protocol was created by MAPS, the Multidisciplinary Association for Psychedelic Studies, and it's actively exploring the potential benefits of MDMA-assisted psychotherapy for treating treatment-resistant PTSD through phase 2 clinical trials. So right now they're in phase 3. This, I believe, is a manual from 2008. But these trials take a long time. So I think I said this last lecture that to get to 40 participants for our psilocybin assisted psychotherapy trial for cocaine use disorder, we started in 2015 and we're still gathering data. We are still recruiting in 2023, 8 years later. So these trials don't happen overnight, and it can be difficult to get participants. So even though there's a lot of like energy and excitement around this, one of the limitations of this line of work is we are geographically limited. So, for the study that I was in, we were recruiting in Birmingham, Alabama, where there's a little bit of a different attitude toward substances than perhaps in Southern California. So MDMA has been described as inhibiting the subjective fear response and increasing positive emotions through evidence, though evidence is mostly anecdotal and based on uncontrolled studies. Another thing for this, as you read, is in order to be included in this study, you had to have had essentially like 3 failed attempts at treating your PTSD. Then the understanding that PTSD is a complex condition characterized by fear, re-experiencing traumatic events, and emotional numbing and withdrawal. Combining MDMA with psychotherapy may help attenuate the fear response or lower it, dampen it, provide access to emotions, and develop a wider behavioral and emotional repertoire in individuals with PTSD. The goal of MDMA-assisted psychotherapy is to restructure intrapsychic realities, facilitate emotional processing, and enable individuals to respond effectively to anxiety-inducing stimuli. So that's the whole purpose of this study. So some of the goals here, the treatment protocol for MDMA-assisted psychotherapy involves a series of sessions with specific durations and components. Non-drug sessions focus on interaction with co-therapists, while the MDMA sessions provide an extended period of therapeutic work, mostly internal. There are baseline assessments and diagnostic interviews that are conducted at each part of the research study prior to administration, post-administration, prior to next administration, at follow-up after they're done with treatment. And essentially with this manual, what I hope you took away is the outlining the core elements of MDMA-assisted psychotherapy for PTSD and to educate therapists about the phases and steps that are involved in this process. So some conditions for the use of MDMA, you want to conduct a thorough participant assessment and preparation. The participant commitments to this is compliance with the dietary and drug restrictions, attendance of preparatory and follow-up sessions, and completion of all evaluation instruments. And then the therapist commitments to this are providing adequate preparation and time during non-drug sessions, ensuring appropriate set and setting during MDMA sessions, and offering sufficient follow-up therapy and support. And so there's things to keep in mind for safety during MDMA sessions, and then rules around the overnight stay and transportation. So some prerequisites and contraindications. So this again is, what qualifies somebody to be a part of this and what can disqualify somebody to be a part of this. So if somebody, for example, has bipolar affective disorder type 1, they are excluded, but other mood and anxiety disorders are potentially eligible for this. Some contraindications for therapy: if the person is pregnant or nursing without effective birth control, if there's a history of primary psychotic disorder or bipolar affective disorder type 1, or if there's familial history. So if you share at least 25% of the genes with somebody in your family who has one of these diagnoses, that would also exclude you. If you are engaging in active purging eating disorder, if you have weight extremes in terms of weight loss, weight gain. For this study in particular, recent substance abuse or dependency, obviously that's not going to be the case with studies that are treating substance use disorders. And then suicide risk of hospitalization, victimization in terms of like harming others, or self-harm. These are some of the contraindications or some of the reasons why somebody would be excluded from the process. So just looking here and organizing this for you in terms of diagnosis and reliability, these are the scales that were used: the structured clinical interview for DSM, the clinician administered PTSD scale or CAPS, the impact of events scale, which measures subjective distress that's caused by the stressful life event. So this is how a person is diagnosed with PTSD and how it's checked in this study. So there's baseline measures here: the symptom checklist 90 and the NEO personality inventory. And then some additional assessments for this study were the working alliance inventory, which assesses the quality of the working alliance between participant and the therapist, super important. The subjective units of distress, this is standard in any sort of psychedelic research. The repeatable battery for the assessment of neuropsychological status, the paced auditory serial addition task, and the Ray-Osterith complex figure task. And then these are the purpose of some of these: neurocognitive functioning assessment, the R-bands, PASAT, and the Ray-Osterith complex figure are administered at baseline and after MDMA sessions to check for cognitive or neurocognitive function. And then we're looking at specific domains that were selected to assess memory and attention that's affected by any sort of psychedelic use. So phases of the preparation: these are the preparation phases. Our phase sets the foundation for the psychedelic or therapeutic work, and it is crucial for ensuring a positive and effective MDMA-assisted psychotherapy experience, broken down into 3 kind of stages: establishing the therapeutic alliance, creating a safe psychological and physical space, and then preparing the participant for what is to come in the sessions. So establishing the therapeutic alliance, gathering information, and participant orientation. The preparation phase focuses on building a therapeutic alliance, gathering relevant information, and orienting the participant to the therapeutic process. These 3 stages here lay the foundation for a successful MDMA-assisted psychotherapy experience. So again, you're wanting to establish a therapeutic alliance, you're gathering information that makes sure that the participant is safe, you're not missing information that might set them up for a not so great experience, and then You are orienting them to the process. What can I expect? How do we elicit my motivations? How do you encourage openness and trust in the process? How do you help them move through difficult emotions? These are all things that the person should feel like, I trust this person so much, I know that I'm going to be taken care of. So creating a safe space, a safe setting is crucial for the participant to fully engage in the MDMA therapeutic experience. This involves establishing agreements, addressing fears, supporting relaxation, involving social support, and ensuring a physically safe environment with appropriate medical care. So that's all outlined here. I just didn't want to necessarily read all of it to you. And then in terms of therapist foundation, the therapist's personal experience with non-ordinary states, including MDMA or other psychedelics, provides valuable insights and benefits in facilitating the therapeutic process. Their role is to support the participant's internal process, maintain empathic presence, and navigate the therapeutic experience while being mindful of their own mental set. So in this training, it is believed that the therapist's own experience with non-ordinary states of consciousness is really beneficial to the therapeutic process. Not that they are under the influence while the participant's under the influence, but that they have some previous experience with that so they can increase empathy for what the participant is experiencing. So then we talk about phase 2 in the protocol. So initiating therapy, the therapists prepare the participant for the MDMA session by addressing concerns, clarifying memory retention, and emphasizing the potential for healing. They encourage vulnerability, provide support, and explain the effects of MDMA in facilitating the therapeutic process. The participant is guided towards a relaxed state and encouraged to embrace a fuller range of emotions, leading to a more transformative experience. So open to a fuller range of emotion, any and everything that happens. So in these sessions, it involves the onset of effects, establishing comfort, and building trust in the healing process. The therapists address anxiety, check in with the participant, and guide the exploration of intrapsychic experiences and traumatic memories. The session aims to promote self-acceptance, empathy, forgiveness, and trust, leading to a deeper healing process and increased emotional well-being. The therapist's role in MDMA-assisted therapy is to create and maintain a safe therapeutic alliance with the participant. They must be self-aware, empathically present, and skilled in navigating intense emotions. The therapist guide and support the participant while respecting their natural healing mechanisms. They balance facilitation and observation, help the participant negotiate inner experiences, and assess emotional stability. The session ends with ongoing support and the potential use of relaxation techniques. So then what do we do in follow-up sessions? The post-MDMA session support includes access to therapists, a debriefing session, collaboration with participant support system, coordination with the primary therapist, so whoever their like kind of everyday psychotherapist is, weekly follow-up sessions, and daily contact with therapists for 7 days after any administration. These measures provide participants with ongoing support, reassurance, and opportunities to process their experiences in a safe and supportive environment. The follow-up and integration sessions are crucial for initiating the integration process, exploring experiences on multiple levels, understanding the unfolding of the experience, introducing focused body work when needed, which is rare. So body work, as you saw in the appendix, is like touching on the participant, like almost like supportive stretching. That is rare. And quite frankly, in my experience, I don't feel super comfortable doing that. I would rather encourage them to do breath work. And integrating the lessons and insights gained from the MDMA session. That's what happens in integration. These sessions provide ongoing support, processing, and coping strategies to facilitate healing and integration into everyday life. which is ultimately the goal of all of this, is what do you take away from this and how do you make it actionable in your everyday life? And then during follow-up and integration sessions, therapists provide support, encourage self-exploration, and facilitate the participants' understanding of trauma. They focus on maintaining therapeutic goals while minimizing their own interpretations, the therapist interpretations. The therapist roles include empathic listening, guidance, and assisting the participant's self-healing process. Integration of the treatment process is crucial for applying the insights gained from the MDMA sessions to everyday life and developing a broader range of responses to anxiety-provoking situations. So ultimately, that's the ending of it, again, is to highlight how do we move this into our everyday life. Then the last thing that I wanted to show all of you is from Appendix A. I'm not going to necessarily go into detail about any of this, but this is how MDMA-assisted psychotherapy is compared to other approaches. So the most common approaches for PTSD treatment are cognitive behavioral therapy, EMDR or eye movement and desensitization and restructuring. EMDR, eye movement, desensitization and restructuring, I think, and psychodynamic psychotherapy. So you can see on each of these therapeutic elements, so prolonged exposure, cognitive restructuring, anxiety management training, what those look like in each of the approaches. So I have 3 slides here of these tables. So the therapeutic element of increased awareness, clearing of tension in the body and other somatic symptoms, transference and countertransference, how is that dealt with and approached in each of these 4 approaches? And then finally, difficulties in therapeutic alliance and the effect of earlier life experience, such as childhood abuse. Again, how is this navigated in these other approaches?